What are the consequences of the doctors and nurses strike on the NHS?
Doctors and nurses are striking because with the rising cost of living and the hard work and effort that they put into their jobs, they're really just fighting for equality of pay. But unfortunately, this is going to have an impact on the patients. So if we think about the short-term consequences, in the short term, there is going to be less nurses per patient. So there is going to be sometimes a safety risk with patients' care, not necessarily having the most efficient and perfect care for the patient. It also means that routine procedures that should have been occurring cannot occur because of safety risks again. And all of these will end up having a larger impact on patient care. So procedures that should have been taking place will have to have been put back onto a waiting list, making these waiting lists even longer, which means that patients' conditions can worsen and can often then make the procedures more difficult and associated with bigger risks the next time they come in for the surgery. And it also means that patients that should have been having care, not necessarily been able to access that care, and again, making patients' lives not necessarily as good as they could, which is a downside to the strikes, but also the nurses and doctors work incredibly hard and they should be paid for what they deserve with an incredibly stressful job that helps such an incredible population.
What are the positive and negative impacts of COVID on the NHS?
Okay, so we'll start with the positives. I think there's been some really positive outcomes as a result of the pandemic. For example, our ability to tackle infectious diseases has really improved. Typically in the UK, we deal with more chronic diseases within the hospitals, and ability to tackle these infectious diseases with knowing the right amounts of PPE, with knowing about the best way for isolation has really helped us so that we can tackle any infectious diseases better. I also think in that kind of same aspect, the idea of resourcing and how to improve the resourcing within the NHS, we had to get a lot of PPE very, very quickly, and I think it's kind of built some connections with different industries that has really had a positive impact. And I also think the new and emerging kind of integration of technology into our care, so the examples of over-the-phone consultations and video consultations that really allow people that can't necessarily come in for appointments, do not have the access. So I think it's helped health inequalities in trying to make sure that care can be given to all, no matter where their location is. But obviously the pandemic has caused quite a lot of negative consequences on the NHS because we had to prioritise COVID patients, and due to isolations and kind of restrictions of healthcare services, it has meant that there have become longer waiting lists for procedures, so patients are having to wait longer, which again means disease could progress into a worse cause, and again when we come to bring them in for surgery, it can become harder and be associated with more risk. Also, I think since not as many people were coming in for GP appointments or were coming into A&E, it means a lot of things have gone undiagnosed, and therefore disease is progressing and patients have not come in when it could have just been, say, a simple chest infection which could have been easily treated with antibiotics from a GP consultation. Instead, has now progressed into something that would require hospitalization and even ventilation in the worst of cases. So I think again, although we have had the positives of widening kind of encouragement of interaction with the healthcare system through telephone and video consultations, I also think health inequalities because of COVID have really widened once again, because those who were not necessarily aware of some diseases, because they're not as well educated, they're going to progress much more and they're going to be in a worse state. I also think with people being in isolation for a long period of time, mental health is going to massively increase since the COVID pandemic. And I think within the NHS, we're really going to have to combat that to help people transitioning into this new kind of state of living which we haven't been used to for quite a while. So overall, I think whilst there has been some really good positive impacts on kind of structurally within the NHS due to the pandemic, I think patients are really going to feel this for the next couple of years.
Sajid Javid states that the current model of the NHS is unsustainable and calls for patients to pay for GP and A&E visits. What are the ethical considerations of this? Outline arguments for and against this proposal.
Okay, so as we're saying, we're beginning to acknowledge that with the budget that the NHS is being given, services are being stretched and that we cannot offer best care that we can to patients. And so some suggestions is that people should be paying for things like GP appointments and A&E appointments. So if we look at the positives from this, we are going to have an increased budget. It's going to ensure that patients attend their appointments because there is an issue of non-attendance to appointments, which can really increase the backlog of treatments and cases. And it's also going to ensure that people are coming to the hospital for the right reasons. But I really think that we need to acknowledge the negatives with this, such as health inequity. First of all, we're living in a high cost of living right now, and that ability to pay for appointments is not accessible for all, and that those who are in need of treatment should be able to access it. After all, like the NHS was founded on the principles that it should be free at the point of care. And so I really don't think that we should lose this, and that as a UK, we really should be catering for the whole population. I think some of the other negatives is that people that often have the ability to pay already are already going into the private sector, and that instead, if we're looking at a way to maybe combat and integrate these two models, that there could be a suggestion that they could be means tested if we really feel that it is necessary to place a charge for appointments, that it should still be accessible to those who most need it. So place a means tested cost for appointments.
What do you understand about the term ageing population? What are the implications of this to the NHS?
Okay, so an ageing population is something that we're going to face in the UK. It's been suggested, I think, that by around 2050, about 25% of our population is going to be over the age of 65, and that's due to our decreasing birth rate. So there are less babies being born, and it's going to end up being a smaller, younger and healthy cohort are going to be looking after a much larger cohort. And I have quite a lot of impacts on the NHS. So with old age often comes risk factors for lots of diseases, and particularly chronic diseases such as diabetes, Alzheimer's, and things like that. And in particular neurodegenerative diseases like Alzheimer's is, which are associated with higher costs. And often these are integrated with comorbidities, and people can have a variety of different diagnoses, making patient care a lot more complicated. Kind of coming along with that, we will probably run into the issue of polypharmacy. So with increasing age comes the increasing likelihood of more diseases, so more medications, and we may run into the risk of kind of iatrogenic factors and symptoms as a result of all of these medications, but also the idea of drug interactions, that some certain medications aren't going to be able to be taken together, and so we really will come into a bit of a sticky situation when it comes to prioritising and what aspects to treat with the patient. And I think another important thing to emphasise is the social care aspect. We really lack already carers and those who work in care homes and roles such as that, and those are the people that really help support the elderly population. And so unless we increase pay for carers, increase kind of the incentives for people to become carers, I think we're really going to struggle to look after our elderly population, because it's not only when they are ill, it is when they are stable and they are out of the hospital setting but might not necessarily be able to live independently. So altogether, I think the aging population is going to become a really big challenge that we all face in the population. And I think we need to improve our social care area in particular so that we can combat this as best as we can.
What are the effects of a shortage of social care beds and provisions on the NHS?
So social care beds are given to those who, whilst maybe medically stable, require extra support. And these are really important aspects of the whole healthcare system, and they're often used when transitioning between a patient that has maybe had a long stay in hospital that requires the extra support whilst they regain their strength back, and so on. And so the shortage of beds has become a real issue. So people are being discharged when it's not necessarily safe to do so, and this is a safeguarding risk. It places people at risk of falls, and particularly with those with dementia, it's often associated with risks for falls and things like that. They require a lot of support, so patients should be given the support that they deserve. But also, as the issue at the moment, particularly of bed blocking. So bed blocking is when somebody who is able to be discharged from hospital cannot maybe be discharged because there's not adequate provisions for them outside of the hospital, that being the place in a care home or a house setup which is accessible for them. Maybe they need a stair lift because they can't access a toilet without it, or things like that. It's becoming an issue which then has a backlog impact on the rest of, say, A&E, where people can then be waiting outside in A&E in the corridors for 20 hours waiting for beds, and it's having quite a knock-on impact on patients that are coming in, but also patients that are coming out. So I really think that the issue of social care beds being lacking should really be combated. I think there should be extra funding and support by the government given to really help alleviate a lot of the stress and problems that are occurring in the NHS right now because of it.
What are the consequences of paramedics striking?
Okay, so paramedics play a real key role within our healthcare system. They importantly observe a patient and quite often can be the first port of call into the healthcare system. So they observe things such as their heart rate, their respiratory rate, and can help them with identifying symptoms. And importantly, they then triage. So for example, they could refer them on to a specialist clinic, which is helping them, for example, if they have breathing issues because of asthma, could refer them on to a specialist breathing clinic, or in obviously the most worst case of symptoms, can take them into A&E and on the way give them the vital drugs and monitoring to ensure that the patient is as safe and as healthy as they can be before they transition on. So they play a really key role. So the impact of them striking has become quite vast. So if we first think about when they transition into A&E, quite often now, because of the strike impact, it means that there has been a huge queue of ambulances outside of A&E that are not able to hand over to A&E because of shortages in A&E. That means that they are then unable to be out in the community and helping the people that are most in need. So that's one issue. Issue as well is because of the striking, they then have to prioritize who they go and see first. So category ones, which are things such as heart attacks and people being unconscious, they can still be treated and they try and hit target time of reaching them. But for category 2, which is often associated with things like falls and chest pains, which do require urgent care, have not necessarily been able to be treated and reached as quickly as possible due to the lack of numbers, and this is putting patients at risk and patient safety at risk and can be associated with deaths. So I think there's kind of the two aspects of the strikes not being able to help as many patients as they can do, and also the backlog within the A&E itself also then having the far-reaching impacts on the community.
Outline the factors that have contributed to increased A&E waiting times in the last year.
So the NHS pledges that for when visitors come into A&E that they should be treated or discharged within the 4 hours, and this time has been increasingly not met. particularly in this last year. And so I think there are three main factors that are associated with this. I think vacancies is a really big issue. I think they said that there's around 47,000 vacancies among nurses. And so that means that there is an increased workload on the nurses, that they are not able to treat as many people as they can. And also the same issue with there being a lack of GPs and the issues to get GP appointments. And so often that means patients are coming into A&E with things that might have been able to be treated by their GP. I think all of this is occurring because there isn't the relative investment that's been going into the NHS, kind of making all of the issues magnified and kind of exacerbate all of the problems within the NHS. And then I think one of the other key ones is the idea of diseases. So things such as COVID have really meant that people's conditions at home when they didn't have as much access to healthcare have really worsened, and it's meaning that things that would have been treated earlier on in the pandemic have now worsened and are now associated with more complex needs that are requiring A&E admission. And then I think there's also the idea of winter. There is always the pressures that face the NHS in winter. And I think kind of what we're facing right now is with the COVID pandemic, people have been sheltered for a very long period of time. And so they've not come across as many of the infectious diseases as we do so normally. And now that we're starting to get our country back up and running, people are facing these diseases and not necessarily being able to combat them as easily. So it's resulting in hospital admissions. And I think kind of the last factor is maybe the structural issues within A&E, and particularly bed blocking is a big issue. So bed blocking is when patients who can be discharged and who are fit to be discharged cannot necessarily because of lack of social care. And what it means is there's been a real backlog. So people are getting into A&E, but they're being treated in the corridors. They're having to wait 24 hours for a bed because there are no spaces on the ward. And that's putting extra pressure on the doctors because they're having to look after all of these extended people before they can transition them on. And that added with all of the things that we spoke about before with the vacancies, with not enough people being there to treat the amount of patients and the increasing amount of complex needs that are coming into A&E, it's really causing difficulties for A&E waiting times.
What are elective procedures? What are the effects of the increasing elective surgery backlog on patients and on the NHS?
Okay, so elective surgeries are non-emergency medical procedures, and they can range from things such as diagnostic testing, they can range to surgeries or even cancer treatment. And there has been a lot of backlog on the waiting list for these elective surgeries. I think I read somewhere that the waiting list has now reached 6 million, which is a huge amount of people. The backlog from all of these is really having an impact on patients. So the longer they have to wait for their treatment, the worse their disease is going to get. And it's also going to mean it's more complicated to treat when they eventually do come into the clinic. So if we think about someone that needs, say, a hip replacement. Hip replacements, I think normally people wait around 12 to 18 weeks on the waiting list, and now people are having to wait so much longer than that, and it's really decreasing their mobility. And with decreased mobility comes a lot of other comorbidities, such as the increased risk of diabetes and things like that from the lack of physical activity, and can also be associated with things such as loneliness. If they don't have the mobility to go out and see people, it can really have an impact on their mental health. So not only is it affecting their primary reason that they were coming in for their elective procedure, it's also having a wide-reaching impact on their general health on the whole. They really are not helping patients at all. And I think there's two ways that we can combat this. I really think that we should be utilising technology a lot more. I think the idea of patients monitoring how their disease is progressing so that we can then prioritise those who need it most, and also to help them understand symptoms and things that they should become alert and aware of. It can really help them communicate with their doctor and hopefully improve their outcomes and prevent any further disease. And I also just think filling our vacancies, offering those nurses and those doctors the pay that they deserve, so that these backlogs and these waiting lists do not have to be occurring, and to try and catch up from the pandemic.
To what extent are doctors responsible for public health?
So whilst doctors are responsible for when we are ill, I also think that they are responsible for making sure we continue good health. And I think quite a lot of this is on a personal level, so offering them health advice such as healthy eating, to stop smoking, and all of those sorts of environmental factors that we know can contribute to diseases. But also, I think it's not just left to doctors themselves. I think it's all about collaborating with the wider UK. For example, I think I've heard of doctors' surgeries that are pairing with local support groups that help encourage people exercising, and whilst they can go on an individual level to help them with their stop smoking, if they join a support group with something like that, collaborating together is going to have a much wider impact on, say, the public's health and making the patients live a healthier and hopefully happier life. And I also think it's important that doctors collaborate with governments who make the policies, and even local councils, where we really encourage healthy living and increase incentives within the population for why we want to be living healthily. So I do think that doctors really have a responsibility for public health, but I also think doctors have a responsibility to collaborate with other people to have the maximal effect.
What is whistleblowing? Under what circumstances would it be appropriate to whistleblow?
Okay, so whistleblowing is when someone reports to an employer something that's happened in the workplace. So for example, in the NHS, that could be putting a patient's safety at risk, or when something is illegal. So if we kind of think of some examples, if we split it into, say, negligence and malpractice. So negligence is not doing the good thing. So if a doctor is missing vital symptoms and missing kind of treatments that should be given to patients that we should be aware of, it can really put patient safety at risk, because they're not getting treated as quickly as we can, and we know that the longer we leave something, the worse the disease is going to progress. And then we can look at the idea of malpractice, so someone that is unnecessarily performing surgical operations, and that again, surgery is associated with a lot of risks such as blood clotting and things like that, particularly in those who are elderly, who are frail and will not necessarily recover from surgery so easily. So if a doctor was performing these surgeries unnecessarily, it could really be putting a patient at harm. And so I think whistleblowing is really important to ensure patient safety, and in the long run, it's helping doctors develop and ensuring that we maintain a really high standard of care so that we can have the best impact on our patients.
What challenges will you face as a medical student?
Okay, so I think we can probably split the main issues that I think you could run into as a medical student into academic and personal. You know, medicine academically is a very long degree. It's 6 years. It is associated with a heavy workload, a lot of hours, and can be associated with burnout and stress. And also the kind of different lifestyle that you would live in comparison to your peers. You know, those that graduate into 3 years and go into a job versus staying at medical school for 6 years until you're 24, 25, until you start earning money, and things like that can be quite daunting, I think, as a medical student, particularly because you can always see maybe the workload that's incoming. You know, you've got those 6 years, you've then got the 2 years of foundation training, you've then got speciality training all the way up until a consultant. I think as a medical student, everything can seem just quite out of reach. And I think, again, similarly, I think a lot of these overlap, but on a personal level, things like that, you can really have a fear. Things such as imposter syndrome, you know, you've really idolized becoming a doctor. when you sign up as a medical student. It's from say 15, 16 when you decide that you're on this career path. And sometimes as a medical student, I think it might be quite daunting that you've set these expectations on yourself and other people may have these expectations. But overall, I think all of these negatives are outweighed by the positives. You know, from my work experience, I've witnessed all of these things, particularly on like the elderly care ward that I was on. There was a lot of burnout and a lot of stress seen by the doctors. They're working long hours, and I know that that's what's coming, but I really feel like the positives outweigh this. I think the intellectual curiosity with the emotional aspect and the impact that you can have on patients' lives really outweighs this. And I think sometimes it can be really hard to not separate kind of your work-life balance. And I think maybe as a medical student, it might come a little bit all-consuming because it's all you can kind of live, breathe and think about. But I think acknowledging that being in medical school is temporary, when you get to the job and you feel more in control and you can have that separation between work and life balance, I think it's an amazing job. And I think whilst medical school can be tough, I think it's something to be excited about rather than to be scared of.